speaker is Professor Andrew John Behnke. He is Assistant Professor of Internal Medicine at the College of the Osteopathic Medicine, Liberty University in the United States. Professor Behnke is going to deliver his lecture on cardiovascular trials and diabetes management. Let's welcome Professor Behnke.
Okay, it's afternoon. I can say good afternoon. Good. This is great, and I know the organizers are very astute to talk about the whole thing. Professor Malik did a really great job in terms of talking about the microvascular complications and how to combat them. I'm going to try to look at more of the macrovascular. Some of the talks are going to be overlapping. Some of this will be old news to you, but I do have a couple surprises here. So bear with me. This is where I look out at my window every day. Campus of Liberty University of Lynchburg, Virginia. From this beautiful building, the School of Medicine. I have no financial disclosures, and you're allowed to take pictures. If you want these slides, please let me know, and I will make sure you get them. You probably know this slide. This is the ADA AASD guidelines for the diagnosis and treatment of type 2 diabetes, and I don't have my little pointer with it, but don't worry about that. It's basically exercise, metformin, and then you have a decision to make. And your decision is there cardiovascular or kidney disease or not? Because when I trained, when I went to medical school, we didn't have that decision. It was sulfonylureas, metformin, insulin. Things have totally changed. And probably because of this one study. This was a study done about 10 years ago. It actually was a meta-analysis done by a cardiologist and a social worker. I think it was Kathy's a social worker. She got a master's in public health. Looking at rosiglitazone versus other drugs in the meta-analysis. And this is really a meta-analysis on other studies, DREAM and ADOPT. And I'm not sure what they were looking for, but they found this unsettling result that in the group that had the rosiglitazone, there were 86 myocardial infarctions versus 72 in the control group. And also even more concerning, there was 39 cardiac deaths versus the placebo group. And the odds ratio was 43% higher of having an MI, and even more striking, 64% more likely of dying if you took this drug that was going to supposedly help your diabetes. So the FDA got a hold of that. It was a big thing. The drug was taken off the market. You certainly can't get it. So the Food and Drug Administration said, look, from now on, we're going to look at all new diabetes drugs and look for cardiovascular toxicity. So this is just a timeline of these studies. Before this mandate, there were studies that mostly focused on efficacy. After this, every drug that came to market had to have cardiovascular outcome studies on it. What I'm going to do in the next few minutes, I know your time is valuable, I want to try to keep on schedule, is to go through a real brief history with you, really focusing on the positive ones, and then talk about a little bit in terms of the future. I think it's important we talk about cardiovascular outcome studies because you're going to see them, and you're going to see them a lot. It's really important to say, what are they looking at? What is the patient population? And what are the outcomes? Not every group had a significantly high amount of patients with cardiac disease. Some just had risk factors for cardiac disease. And I think it plays important in terms of when you get to the answers. So the first group looked at were the DPP-4s, because they were kind of the first class coming out after all this happened. And the first study was sitagliptin, the examine study, and 5,000 patients with type 2 diabetes, about 2,700 on sitagliptin, similar number on placebo. And the FDA sort of said, you really want to prove at least you're not going to make things worse, at least non-inferiority. And they defined that as a hazard ratio of 1.3. And this study did exactly what it's supposed to do. It showed that these drugs, sitagliptin specifically, did not have an increase in cardiovascular toxicity. No more pancreatitis, no higher rates of cancer, renal impairment, or severe hypoglycemia. And this is the odds ratio. You can see the primary composite endpoint was worse, cardiovascular death, non-fatal MI, and non-fatal stroke. And those are the general composite endpoints, those three. Cardiovascular death, non-fatal MI, stroke, death of any cause, secondary thing, basically a wash. When sitagliptin came on the market, sitagliptin had the same responsibility, so the TCOS trial was done. And basically it was more of the same, a lot more patients. These are pretty big studies, 7,000 patients in each arm, looking for non-inferiority, patients with type 2 diabetes. And these patients actually had more cardiovascular disease than the example study, but the results were basically the same. The hazard ratio was 0.98 for the primary outcome and 0.99, essentially unity for the secondary outcome. So really kind of nothing new until EMPA-REG comes out. And EMPA-REG kind of really shocked the diabetes and cardiovascular world because this was the first study that actually showed not only non-inferiority, but superiority. This was a 2-to-1 ratio in terms of the study, so two groups, 2 times the amount of patients who were at EMPA versus 1 time with placebo. Patients who had cardiovascular disease. You really had to have some kind of cardiovascular disease to get an EMPA-REG. You had either a heart attack, a stroke, or peripheral vascular disease. And they found not only non-inferiority, but lo and behold, they found superiority, especially when it really mattered, cardiovascular death and all-cause mortality. So now you have a drug that's not only treating your diabetes, treating your blood pressure, you're losing weight, you're also not dying of a heart attack, or you're not dying of any cause. Wow, really, really kind of earth-shattering. This is scattered the hazard plots. Really come off that good. If you want the slide I've given you, you can see the difference was actually sustained and quite early. As Professor Behnke also said, there was other studies looking at renal outcomes, and they can see a definite decrease in the amount of nephropathy, amount of membranonuria, and initiation of renal outcomes. So there was a renal benefit as well as a cardiovascular outcome. And again, if you like the curves like this, you can see them that way. Now, there were some side effects with the EMPA, but they were mostly side effects that didn't require significant intervention, genital urinary infections and candida yeast infections, a little bit more bowel inflammation, but really not a lot of serious adverse events that we're seeing. When CANA came out, the same study was done and had similar results, but these are patients with high cardiovascular risk, but not necessarily cardiovascular disease. So when they ran the numbers, they weren't as impressive. So again, different population. It did meet the primary composite goal, did not decrease cardiovascular death or non-fatal MI. Mostly it was powered by decreasing heart failure and hospitalization for heart failure. All-cause death was barely positive, and again, there were the renal benefits. Now, most recently, DAPA has come out with a declared TB58, and this drug, like an SGLT2, lowers blood pressure, lowers body weight. There was a suggestion of decreased cardiovascular outcomes. The MACE was not met. It was close, hazard ratio of 93, but there was a decrease in the amount of heart failure and cardiovascular death. You got those two together, it was primarily heart failure. Did not really show an a priori decrease in cardiovascular death, mostly heart failure. But if you got those two things together and you graphed it out, you did see some superiority. In fact, I think just this week, DAPA does have an indication to prevent heart failure. So that's something that they are using. So if you kind of look at these drugs together, if you look at it just in terms of this graph, you're going to say, oh, wow, EMPA is much better than CANA. But again, you have to realize it's not apples to apples. In a different population, we started with EMPA, then DAPA. I think the most important thing to say with this is these drugs do work in the cardiovascular system, whether it's preload reduction, ketogenesis, lipids, who knows, to help patients with cardiac disease. So the next group on the market were the GLP-1s, and the first GLP-1 study was Lixi, the Lixa study. Kind of people were thinking that Lixi would do a good job, but Lixi did not show to have any significant cardiovascular benefits. So the first GLP-1 trial did not show a benefit. There was definitely not any worsening. There was not inferiority, but not superiority. And then, of course, came LEADER, and LEADER was liraglutide, and LEADER did show cardiovascular outcomes that were beneficial. SGLT1 compounds are very provocative. They don't just work on the beta cells. They work on the heart, they work on the kidneys, they work on the brain. So there's a lot more potential benefit for these drugs that we'll talk a little bit about when they have this talk in a few minutes. But getting back to LEADER study with liraglutide, for positive cardiovascular outcomes, positive cardiovascular death outcomes, and nephropathy was better. And you can see this in the Kaplan-Meier curves of a decrease in primary outcome. Semaglutide was sustained. Semaglutide is a weekly GLP-1, and sustained did also show a cardiovascular benefit. So now you don't have to worry about taking this just once a day. You can take it once a week with semaglutide. There was an increase in retinopathy with semaglutide. Don't really know why. It's been criticized and examined, but really to date, we haven't found out why that is, that there was an increase in retinopathy. But nephropathy was better. Non-fatal stroke was a little bit better. All-cause mortality as a composite endpoint was better than SEMA. And then DULA, the REWIND study, which was just published at the AAPA meeting in San Francisco this summer, showed a positive endpoint. And this drug was one of the first drugs to have a reduction in stroke. Because we know we do a pretty good job with glucose control, we do a pretty good job with microvascular control. We're actually getting some progress in heart attack, but we don't do a good job with stroke. Now, does anyone else know another drug that decreased stroke diabetes? Well, I heard pioglitazone, and that's true. Before this whole thing came out, Proactive was a study looking at pioglitazone. And even though there was not a decrease in death, there was a significant decrease in both fatal and non-fatal stroke, significantly so. So pioglitazone is still available in the U.S. It's generic, it's relatively inexpensive, and I think this is something to think about if you have a patient, especially who has a high stroke risk. I'm going to end with talking about semaglutide. This oral semaglutide is probably the latest and greatest drug that's available on the diabetes market. We all know semaglutide is a GLP-1 analog. It's given by injection. Jeepers, wouldn't it be great if we could have it in a pill? Because I'm not sure what people are like in this part of the world, but Americans, we don't want to take a shot. We just want to take a pill with our McDonald's sandwich. So this was a group of studies looking at oral semaglutide. And I'm not going to go through all of them. I'm just going to go through two. One was the Pioneer 3 study, which compared oral semaglutide versus injectable GLP-1, sitagliptin. Oral. And come up with that. Actually, not bad. So if you have oral semaglutide versus subcutaneous liraglutide, you have actually the same amount of hemoglobin A1C reduction. So a pill is just as good as a shot, but you actually lost more weight. So you're losing 5 or so kilograms with a pill, and you're only losing about 3 kilograms with a shot. So, well, that's kind of good, take a pill every day and lose more weight than taking a shot once a week. But even more exciting was the Pioneer 6 study, which showed a significant decrease in composite non-fatal MI, but mostly death from cardiovascular cause. Now, there's not a lot of data here, but if you look at the hazard ratio, it's basically, you're going to cut your risk of dying to 50%. So that's a lot. Now, again, not a lot of numbers. It's 15 events versus 30 events, but the numbers did make sense. So if something is on the market, it's going to be coming here. These drugs, you have to be careful when you give not enough, it doesn't work. When you get too much, they get sick. And I think we all know that when you go up on the doses of the GLP-1s, you get the nausea. So with this drug, you got to take it carefully. You can't eat for a while. You got to be very careful in terms of dose titration. It's not as easy as just taking a pill a day. Some of you listen to these studies and they're like, that's great. Dr. Behnke, you're talking about all these drugs, but my patients, they can't afford these drugs. Maybe we don't have these drugs. Is there anything that I can take away from? Hopefully, you all have access to metformin and sulfonylureas. And this was a study that was just published in JAMA, looking at patients who are either on metformin or sulfonylureas, and they actually looked at people with somewhat decreased renal function. So these are patients that had eGFR greater than 30, but less than 60. So some stage 3 renal patients, which traditionally back in the day we wouldn't use metformin for. Now we sort of are a little bit more stalwart in terms of using it down to eGFR less than 30. And this was a cardiovascular outcome study. It was a retrospective study, so it wasn't a prospective study. But if you look at the time that they reached this kidney threshold and stuck on the metformin versus staying on the sulfonylurea, because back in the day, as soon as the eGFR was less than 60, you'd stop the metformin, put them on SU or insulin. You actually saw the folks that stayed on the metformin had decreased cardiovascular outcomes, and they used the same 3: death, MI, and stroke. So it seems that, metformin beats sulfonylurea. I think we've said that for a long time. But now we have some data to prove it in terms of cardiovascular outcomes. And I'm not trying to say that to say you should use one drug versus another. I just want you to know that cardiovascular outcome trials are going to be very popular. Know exactly what they're looking at and know what the data shows. So in summary, cardiovascular studies are increasingly important in evaluating drugs for type 2 diabetes. Recognize what is being looked at and what drives the results. If you look at DCOTIMI, really no decrease in death, MI, or stroke. The only thing that really drove that was heart failure. So that's something to think about. Very good drug for someone who has heart failure, who has a high risk for heart failure. But probably doesn't really have any benefit if you want to worry about it, consider stroke risk. SGLT2 inhibitors have positive cardiovascular outcomes to a different degree, EMPA, CANA, or DAPA. Oral semaglutide has positive cardiovascular outcomes that may be more effective than injectable semaglutide. And finally, just something for the common man, metformin has better cardiovascular outcome studies versus sulfonylurea studies. Thank you very much.
Thank you, Professor Behnke, for this excellent presentation for the cardiovascular disease. And now we have a time for the discussion. So anybody have a question for Professor Malik or Professor Behnke? Please.
Thank you. After these cardiovascular safety trials, the ADA standard of medical care is changing the focus from glucose lowering to cardiovascular safety. In 2016, they are talking about weight loss and blood pressure, decrease in blood pressure, and then after 17, decrease of cardiovascular mortality, and then in 18 about the MACE, and then 19 about the CKD and atherosclerotic cardiovascular disease. Do you think that is a part of marketing of industry as they're playing to marketing the product more than this safety valve.
I think the question is to you, in terms of cardiovascular outcomes in industry driving the agenda.
Well, coming from America, we are marketing, and our economy is largely a part of medical marketing. So that definitely drives it. However, having said that, I do think that cardiovascular disease is the #1 killer of patients with diabetes, especially type 2. And any drugs we can use to combat that is very helpful. I think, if anything, records showed us that. And that's why I included that slide with the proactive study. You don't get a lot of drug reps telling you about pioglitazone decreasing stroke rate, but it's there. And I think you as a provider, the ultimate decision is you. It's not what the marketer is saying, it's you.
Yeah, I mean, I think we sometimes have an overcritical view of what industry does. The reality is that before we were mandated to do cardiovascular risk reduction trials by the FDA, we were giving drugs that were actually causing increasing deaths. Sulfonylureas, there is data to show that. Now, you might argue that in your population they can't afford anything else. Fine. But if we have a choice, I would now, if I was the patient, what would I want? I tell you, I would not want a sulfonylurea. Simple.
Yeah.
Yes.
Yes, dear. Yes. I believe. Yes. Thank you, Professor Malik, for your elegant talk. Every year you come with the news about the treatment of neuropathy or the triopathy. This year you add vitamin D with a very large dose. And I would like to ask, what is about growth hormone and testosterone in the treatment of diabetic neuropathy? This is the first question. The second one, as regard the treatment of hypertension in patients with functional hypertension. In patients with diabetic orthostatic hypotension, when the baseline is flat, what's the best drug for the treatment of hypertension?
Okay, so in terms of testosterone and growth hormone, I'm not aware of any studies that have been done for neuropathy. I'm not aware of them. If you know, then maybe there is something there. In terms of treatment, this is always difficult because on the one hand, you've got a patient whose blood pressure is falling, and on the other hand, they've got diabetic renal disease or hypertension that you want to treat. So what I tend to do is actually give the blood pressure lowering drug, an ACE inhibitor, at night. So actually they sleep through it, so at least they get some protection. That's the only way to deal with it. It's just the timing of the drug you give at a different time. Yeah.
My question about the diabetic medication available for diabetic neuropathy. Is it for symptomatic relief or can cure or reverse the condition of diabetic neuropathy? And any role of vitamin B supplement in treatment of diabetic neuropathy? Thank you.
So the current FDA-approved therapies for neuropathy are really for painful diabetic neuropathy. So they are for symptom relief. They don't have any underlying benefit in terms of disease modifying. However, I've shown you the data that suggests that ACE inhibitor improves nerve conduction, statins improve nerve conduction, fenofibrate is likely to be having an impact, and our latest data suggests that GLP-1 therapy is repairing nerves. So those are what I call disease modifying drugs, and that will be the future, I think, in terms of underlying disease. Vitamin D, high dose? Yeah, so in that particular study, actually, we deliberately used a very mega dose because we wanted to make sure that we gave a good dose and there was compliance. In my clinical practice, I actually use lower doses, but on average, most patients need 4 to 5,000 units daily. So I actually give 50,000 units of D3 or D2 daily for 21 days. And then I give 100,000 once a week.
Professor, thank you for the presentation. I have a question mark regarding the studies related to sodium glucose transporter inhibitors with a positive results regarding the cardiovascular and kidney progression, kidney disease progression. The comparator are either placebo or active, but without controlling of diabetes in the control group. All through the studies, the glycated hemoglobin in the control group continue to be above 8. So, the results of these studies, can we consider it related to the molecule or to the control of diabetes? I think this is a very important question mark, and as you know, we have a study started in the year 2014 comparing 4 comparators regarding the cardiovascular. The results will be in the year 2021, but it's not including in this study the sodium glucose. So, in addition of having the AASD, the American Association, the EDF, and so on, we have another big foundation in diabetes, and they do not use the benefit of these studies in their algorithms. Thank you very much.
Thank you very much, Professor. And you bring up a very good point. And we can talk about this if we go to the AASD. You can talk about this for several hours. Why these studies were positive. And you can say it's decreased preload. You can say it's better glucose level. You can say there's a lipid benefit from these drugs. Yes, there was a reduction in A1C. It was small. It was about 0.3, 0.4, and it did persist. Some people have argued that. Some people have argued against it. My take is, if you look at these drugs as a whole, though, they do have some cardiovascular benefit. What I think is going to happen, just sort of mimicking what Dr. Malik had said, I think the GLP-1s are going to actually prove to be even better in terms of a cardiovascular toxicity approach. Why do I say it? Because of some of the science that I've been reading and looking at. We really have no idea how these drugs work in total, but I think more will be coming out. Do you want to comment any more on that, Dr. Malik?
Okay, I think we have to finish this session because we have another session there. So on behalf of you all, I'd like to thank our speaker, Professor Malik and Professor Behnke, and thank you, Dr. Abdulazar.